saw a t-shirt the other day. It said champagne made you do it.
Okay, so let's finish blood. I can't remember where we stopped. Feels like it's been a month.
It's page 4.
Did we talk about testosterone?
No.
Okay.
Let's talk about it.
Let's talk about testosterone. One of my favorite nonfiction books about physiology is called The Trouble with Testosterone. Love it. So good. So, this is not troublesome about testosterone. This is actually cool about testosterone. Testosterone, if you compared the same volume of blood in male and female, typical male-female blood, in a cubic millimeter, which is about the size of a big drop, males have about 1 million more red blood cells, almost 1 million more red blood cells per cubic millimeter. That means their oxygen carrying capacity is significantly higher in a post pubertal male than it is in a female at any point. So greater oxygen carrying capacity. That also, of course, means that since they have more red blood cells per unit volume, they have more hemoglobin than females do. Good? Okay, so let's start talking about hemoglobin a little bit. Hemoglobin, I know you've seen hemoglobin before. Let's look at it again. Okay, hemoglobin has 4 protein subunits, each of which has an iron-containing portion at the middle called the heme group. You see that iron-containing portion at the middle? The importance of that one is that oxygen gas rides on the heme portion. That means that per hemoglobin molecule, you can carry 4 molecules of oxygen gas. Okay, males and females do not differ in the look or the function of their hemoglobin, but they do differ in the amount of hemoglobin because of different numbers of red blood cells. So the primary function of hemoglobin you've known forever. It's to carry oxygen around in the bloodstream. And you may or may not know that it also carries carbon dioxide around. So we'll talk about that in just a second. Okay, so the primary function of red blood cells and the hemoglobin within red blood cells is gas transport. So this should sound familiar to you. Basically, when the blood goes through your pulmonary capillary beds, what happens is you load oxygen onto your hemoglobin ferry, not flat, but the other kind, with the horn. So you load it onto your hemoglobin ferry, and when oxygen binds to iron, it makes blood redder. Yes? Okay, so that's what happens here. And then when oxygen binds to the iron on hemoglobin, it is called oxyhemoglobin. And oxyhemoglobin is bright red. Okay? And then, so that's what's going to happen in the pulmonary capillaries. And then you're going to pump it to your systemic capillaries, and then oxygen is going to get off the ferry, right? And then you will form deoxyhemoglobin. Does that make sense? So oxyhemoglobin, deoxyhemoglobin, over and over until you die. Okay? But what you may or may not know is that hemoglobin also carries carbon dioxide. So most of your oxygen is being carried around inside your red blood cell on the hemoglobin molecule, but about 20% of your carbon dioxide is as well. Carbon dioxide doesn't outcompete oxygen, though, because it doesn't ride on the heme portion of hemoglobin, it rides on the globin portion of hemoglobin. Meaning that if I go through a systemic capillary bed, I could pick up some carbon dioxide before I dropped off my oxygen, and they wouldn't outcompete one another. Does that make sense? Okay. When carbon dioxide is riding on hemoglobin, it's called carbaminohemoglobin. It doesn't change the color at all, so you wouldn't have any big indicator of what it was going to do. So, last little bit before we talk about anemia, what happens to red blood cells? Red blood cells are really recycled. They get used up pretty quickly. Usually, well, it's not super quickly, but usually they last about 120 days in circulation. And what happens to them is every single time they go through the liver and the spleen, they are looked at by the macrophages in the liver and the spleen to see if they've got one more round left in them. If they've got one more round left in them, then you let them circulate once more through. If they don't, and they look like they've had the crap beat out of them, then you recycle them, and you actually keep all the precious parts, and then you send all of the parts that you can't recycle to the landfill. And the landfill is basically poop and pee. So what are the precious parts that you recycle? Well, what you do with an old red blood cell as it goes through the liver is you recycle it and you send the iron right back to the bone marrow so you can do what with it? What are you going to do with it in the bone marrow? Make more hemoglobin, exactly. And you send the amino acids from breaking down the globin portion back into the bloodstream because amino acids are valuable, right? Because you can use them for protein synthesis or you can use them for anabolic or catabolic processes, either one. What about the waste products that you can't get rid of or you can't recycle? What you do with those is you send them to the poop and the pee. And really what happens is they actually get broken down and they get dumped into, sent to the gallbladder. And they are actually made into a bile pigment called bilirubin. And bilirubin is stored in the gallbladder and then it's dumped into the digestive tract. It also gets dumped into the kidneys. It is what makes your poop that color. All of those broken down red blood cells are the reason your poop is brown, right? Unless you ate a whole bag of Oreos yesterday, and then that's the reason your poop is brown. And it's also the reason your pee is that color. And it's sort of this greeny, unpleasant color that you never want to paint a wall, right? You don't ever want anything on your walls with poop or pee, that kind of greeny, yellow color in it. That's what it is. And my son just loves knowing that. I can't even tell you how many other 10-year-olds he's told you. That color of your poop, it's because of dead red blood cells. And they're like, you are disgusting. But I'm brilliant. Go ahead. Yes?
Yes, ma'am. Why do they test, when they test the blood, they'll test also for bilirubin?
It is an indication of your liver and kidney function, how readily you get rid of the bilirubin that is formed. And if your liver and your kidneys are not functioning properly, it will start to deposit. It'll be in your blood, but it'll also just start to deposit on your skin. Sometimes that happens with babies too. You ever put them under the light?
Babies, it's not jaundice, but that's why.
It is jaundice. Yeah,
why.
bilirubin depositing in your skin.
That's why they're yellow.
Yeah, that's why they're sometimes yellow, and you have to use a light that breaks down the bilirubin from their skin, and then their liver and their kidneys catch up.
And that's why alcoholics sometimes.
Yes, alcoholics will turn jaundice because their liver is trashed. Okay, so let's just talk about a couple of different kinds of anemia. We're going to go through anemia really quickly because I only will probably ask you one question about it. Anemia is anything that reduces your oxygen carrying capacity. So less blood, less hemoglobin in the blood, hemoglobin that doesn't fold right, any of these numbers, a deficiency of something that you need to make hemoglobin, all of those could cause anemia. So anemia is a really broad, topic. Which gender is more likely to have anemia? Females are, because they had less red blood cells to begin with, and also menstruating females are going to lose red blood cells and tissue during the process of menstruation. So there are several forms of anemia that are pretty much gender neutral, but in all of them, the females are slightly more likely to have it because they just didn't have as much to begin with. So symptoms of any form of anemia, you're going to be freaking tired because you don't have oxygen carrying capacity. You're likely to be kind of pale, right? A little chilly, all of that kind of stuff. So examples. One of them, if you lose blood, you're going to be anemic afterward. Whether you lost it on accident, like you hemorrhage, or you gave blood, right? So when I was 18, the first time I could give blood, I gave blood and then went and worked out because I was really smart at 18. Yeah, and then I slept for like 72 hours. So, yeah, you don't do that. That was not a good idea. And I think somebody probably told me, but you know, 18-year-olds are brilliant and they don't listen to anyone at all, right? Oh my God, my 15-year-old. I'm going to murder her. She questions everything I say. Now, we tried to make freaking banana bread, and she was like, baking soda, baking powder, the same thing. And I'm like, they literally are not the same thing. She's like, I don't believe you. It's like, oh my God! The whole weekend was like that. Everything. Oh my God, I'm not talking to you anymore. Okay. So I just had to get that out, and now it's on tape. She'll listen to it. Okay. She'll know the error of her ways, like she ever would listen to me talk if she didn't have to. Hemolytic anemia. So if anything busts your red blood cells, like malaria. Do you guys, malaria pathogens are intracellular red blood cell pathogens. And what they do as part of their life cycle is they cause hemolysis, right? And because they do that, can you see that anemia and being really exhausted is one of the characteristics of malaria, right? One of the symptoms of malaria, right? So a mismatched blood transfusion could do the same thing. mismatched blood transfusion, hemolysis, agglutination, you're screwed. Aplastic anemia is when the problem doesn't occur in the bloodstream, the problem occurs in the bone marrow. So if you have a chemical or radiation that kills off your bone marrow, then you're going to be anemic associated with it. If you kill off the myeloid stem cells that make red blood cells, most white blood cells, and platelets, then not only are you going to be anemic, but you're going to have immune system problems and clotting problems, right? And by the way, sometimes they have to do that for the treatment for leukemia. Leukemia is a bone marrow cancer, right? And you have to kill it off with chemicals or radiation so that you can get rid of the cancerous tissue, and then you can have bone marrow transplant afterward. But anemia is one of the characteristics, one of the symptoms associated with that. Nutritional anemia, if you are missing any of the components that you need, vitamin B12, folic acid, a bunch of the other ones, iron, then you can have nutritional anemias. A lot of times women can avoid the post-menstrual anemia if they will make sure that their iron levels are really high before they menstruate, but it's sometimes hard to avoid. Renal anemia. If anything is wrong with your kidneys and they don't know when to release EPO, can you see that you can have anemia associated with it? So kidney failure, interestingly, often manifests with anemia as well. So pernicious anemia, I like this one because pernicious sounds like an old man word, pernicious, and it is an old man disease. It's an old people disease. So what happens is, in order for you to make red blood cells, you need vitamin B12. Usually we don't have trouble getting vitamin B12 in our diet unless you're vegan. It comes from meat and animal products. But you can't absorb it in the absence of something that you make in the lining of your stomach and dump in your digestive tract called intrinsic factor. And when you age, you just stop making adequate amounts of this. So since you stop making it, it doesn't matter how much B12 you eat, right? You can't absorb it. Does that make sense?
That's why older people have B12.
Yeah, older people have B12 shots, not B12 supplements, because you can't absorb the B12. Does that make sense to you guys? So they're usually B12 shots. And then the hereditary anemias. Is there anybody in here who hasn't learned about sickle cell anemia before? You've all learned about it before. Okay, so with sickle cell disease, basically what happens is, just briefly, I won't go into it in much detail. If you get, it's a hereditary disorder in which there's a single base substitution in the DNA that causes a single amino acid substitution. And what it does is it causes the hemoglobin to fold differently. And whenever you get it into hypoxic situations, low levels of oxygen, the cells will sickle. How well does it look like those cells will go through a capillary? No, it's terrible, and it cuts off the oxygen flow to the tissues downstream. It's supposedly incredibly painful as well. And a lot of times people didn't live, historically speaking, with sickle cell anemia into the reproductive years. And yet it's still really, really common, especially in people of Central African descent and some portions of Asia, because although it's an autosomal recessive disorder and you need a double dose to have the disease, if you were a carrier of sickle cell, you were relatively immune to malaria. So the carriers survived disproportionately. So it's still really common in certain populations, even though it's potentially deadly and is often really deadly. Okay, and then there are other anemias as well. If you are really inactive, your body just says, you don't really need that many red blood cells, you don't do anything, right? And so you can have anemia because of inactivity, and you can also have anemia associated with hypothyroidism, just because of the thyroid metabolism of everything, including the bone marrow. Okay, so the only hard part of this set of notes is this, and it actually is only hard the first time you hear it. The second time, I will simplify it for you and you'll be fine. So what we need to talk about is hemostasis, not homeostasis. Hemostasis is the cessation of bleeding after an injury. It is very often called clotting, but just so you know, clotting is only one stage of hemostasis. Notice that it's not homeostasis, and if you put homeostasis, that ain't a spelling error, that's just wrong, right? So hemostasis, basically blood stability. So it is going to involve platelets, but it's not going to be limited to platelets. And it's kind of complicated. It involves multiple cascades. I will simplify it for you. Okay, so basically there are going to be 5 stages. So what I want you to imagine is that somebody just did a blood draw on my median cubital vein, right? So I got a hole in the vessel, but I don't want to lose the blood, right? So how does the process of cessation of bleeding occur? Does that make sense? So there's 5 stages. So we're going to go through them just learning the names, and then we'll go back and add all the details to the stages. The first stage is vasoconstriction. And vasoconstriction, what do you guys think? Should vasoconstriction happen upstream or downstream? Upstream, exactly. So if you've got a hole in the hose, you kink the hose upstream, right? So this vasoconstriction phase happens, and it's basically going to stay vasoconstricted for quite a while until you actually are able to repair the damage, just like you would do with a hose. Does that make sense? And then the second phase is when you start to attract platelets to the area, and you form what's called a platelet plug. And a lot of people think a platelet plug is a clot, but it's not. It's a platelet party. Platelets just get together and they start to attract other platelets, and they have a little platelet party. And they're basically just congregating at the site of damage. And if the platelet party was not adequate to stop the bleeding, then you will start a clot after the platelet party. So the clot is actually something different. Platelet parties are just platelets congregating, but a clot is all of these sticky fibers. Okay? So what a clot is at the site where you have the platelet party usually, what's going to happen is you will start to make all of these insoluble sticky fibers. Think spider web. Does that make sense? And the spider web will catch anything that goes by, and by doing that, it really should plug the hole, right? And while you have the hole plugged, what will happen is behind the scenes, you're going to start actually healing the hole, right? You've got it plugged, and you're going to start healing. So the next stage is platelet plug formation, and then the clot itself is called the clotting phase or coagulation phase. That's when you're forming the spider webs. And then the next phase is when you start pulling the sides together. And pulling the sides together is when the spider web starts pulling on the sides of the damaged vessel to pull it together. That's called the clot retraction phase. The clot retraction phase you have probably noticed if you've ever had a road rash. Have you ever noticed when you had a road rash, when it starts to heal, it tightens and you get this clear fluid that's pushed to the top, clear yellow fluid? That's called serum. What that is blood plasma minus the clotting factors which stayed in with the clot. So that was clot retraction, and then the last phase is dissolving the clot when everything is done. So the last phase is called fibrinolysis because the spiderweb stuff was made of fibrin. Okay? So vasoconstriction, platelet plug formation, coagulation, clot retraction, and then fibrinolysis. And we will go through, there's only one of those that's hard at all. The coagulation phase is the only one that's hard. Okay, so let's go back to the beginning and talk about the first phase. So the first phase is vasoconstriction. We really don't know why vasoconstriction occurs. They think it's because of some paracrine agents that are released upon damage. But some people also think that it might be a nervous system response to damage. So like, ow, and you just like do vasoconstriction. But what it is, we know what's happening inside, we're just not quite sure why. What happens, the smooth muscle in the wall of the vessel constricts, okay? And when that occurs, the vessel, of course, gets smaller and reduces blood loss. We do know that some paracrine agents are involved, and some of them are ADP, which in this particular instance is just used as a paracrine agent, and serotonin, not neurotransmitter here, just paracrine agent, and then one that's called thromboxane A2. And please note that vasoconstriction lasts for up to 30 minutes because it takes a while to actually heal. That makes sense? Okay, then the next phase is platelet plug formation. So this one's kind of interesting. So with platelet plug formation, what happens is the platelets need some indicator to know that something is wrong, that something is damaged. Does it make sense to you that in a healthy blood vessel, the only kind of tissue that a platelet should encounter is epithelial tissue in a healthy blood vessel? What if a platelet encounters a collagen fiber? Does that mean damage has occurred? Collagen is in what kind of tissue? What general kind of tissue? Yes, it's in connective tissue. You should not encounter collagen fibers in an undamaged vessel. So what happens is, if you encounter a collagen fiber, right here, exposed collagen fibers, the platelets actually start to change their chemistry a little bit, what they do is open and close some ion channels, which makes them kind of polar, kind of electrically attracted to other platelets because you got like a positive end and a negative end. So the platelets like stick to the exposed collagen fibers and then they start attracting other platelets, right? That makes sense? So the platelets become sticky, but what it really is electrically attracted to other platelets, okay? So what happens is collagen fibers say something's up, platelets stick to the collagen fibers, start attracting their friends, and they start a platelet party, right? And this is called a platelet plug. Does that make sense to you guys? So what kinds of things are involved in platelet plug formation? ADP, again, thromboxane A2, it's just a paracrine agent, and then some other stuff. One of them is called von Willebrand factor. I don't know if you guys have heard about von Willebrand's hemophilia. There's a form of hemophilia in which you don't make one of the paracrine factors that start this whole process. And if you don't get a platelet plug, it's harder to get a clot. Okay, so we'll see that this usually precedes a clot. So what other kinds of things are involved in the platelet plug formation? Epinephrine, serotonin, ADP, prostaglandins, thromboxane A2, all of them are working together to attract more platelets. And so what you do is you attract platelets, which then attract more platelets, which then attract more platelets. It sounds like what to me? Positive feedback loop, right? And that's what it is, because when you have a hole, how quickly do you want to plug it? Yesterday. You're like, I want to plug that hole yesterday. So what this does is very quickly attracts platelets to the area. And just so you know, platelets love to play with other platelets. If you ever let one sit for long, it's going to try to attract friends to the area. So this whole platelet plug formation usually takes about a minute. Sometimes, if it's a teeny tiny hole, that's adequate to plug the hole. But if it's a bigger hole or at higher pressure, you're going to need to keep going to the next phase, which is coagulation. Okay, so the platelet plug, why does the platelet plug? If it's a positive feedback loop, guys, if the platelets are attracting platelets, which are attracting platelets, which are attracting platelets, why does it not keep going and fill up the entire vessel? Why every time you get a blood draw in your median cubital vein, do you not fill up the entire damn vein? And the answer is that although this is positive feedback, the healthy, undamaged cells are releasing things that say, move along, platelets. They're releasing nitric oxide and prostacyclin, and all of those are saying, no platelets, do not stop here. Does that make sense? So do you see that you got positive feedback at the site of injury and negative feedback on the edges, right? And it's limiting the size of the platelet plug. Is that good? Okay. All right. So the platelet plug is not the same as a clot, but it very often precedes a clot for reasons we'll see in just a second. Let's talk about what aspirin has to do with this story. Aspirin is effective for pain because it inhibits prostaglandin synthesis. It's also effective as an anticoagulant because it inhibits prostaglandin synthesis. Prostaglandins was one of the things that it was involved in the positive feedback loop. So a lot of people, myself included, are supposed to be taking aspirin as an anticoagulant to prevent inappropriate clotting because I have a heart problem, right? And you take a smaller quantity and you take it daily, 80 milligrams. They used to call it a baby aspirin, but we're not supposed to give babies aspirin anymore. We used to. Yeah. Yeah. You probably had it. I had it when I was a baby. Yo, they taste delicious. I used to love those things.
I was always getting sick. So
I was like, oh my God, give me some baby aspirin. Especially since my mom was a hippie and we were not allowed to have any sweets, I would figure out how the hell I could get a Flintstone vitamin or a baby aspirin out of that woman. One time I sat behind her papasan chair. Do you know what a papasan chair is? Those big old hippie chairs that are woven. And I ate an entire thing of Flintstones, an entire bottle, and had to have my stomach pumped. All because she wouldn't give me a cookie.
Darn that one.
I know. Okay, back to focus, Melanie. Focus. Okay, so what this one does is aspirin inhibits prostaglandin synthesis, so the platelets cannot form a platelet plug adequately. And if you can't form a platelet plug adequately, you're less likely to form a clot. Okay, and clots are the problem with people like me. Inappropriate clots can form. So the problem is also, though, that if I take aspirin every day, which I don't and I'm supposed to, if somebody, like if I run into something, and I don't know if you guys have noticed, but I'm not the most graceful person you've ever seen, because I'm almost falling off this damn thing all the time, I get huge bruises, right? Just because you're also less likely to form appropriate clots. Okay, so that's how aspirin works. It's actually not an anticoagulant, it's antiplatelet plug. Okay, so we'll get to the next stage. So now the next stage, I have a platelet party that's started, right? Maybe that was not adequate to plug the hole. So then you go to the next stage, and the next stage is the complicated one. It'll be really, really messy, and then I will clarify it for you. So don't get frustrated in the middle. So the next stage is called coagulation. And coagulation is the formation of the spiderwebby clot, okay? And so what happens is if you let blood sit around for a little while, it will start to clot. I don't know if you guys have ever seen blood like sitting out on a table. If you let it sit for a second, it will actually start to become kind of gelatinous. Have you ever noticed that at the edges it also pushes out like that clear yellow fluid? That's serum. So basically clot formation starts to occur whenever you let blood sit for very long. And the serum is the plasma minus the clotting factors which stay in. So blood gets kind of gelatinous. And the gel is a clot that's basically made of these insoluble fibers and anything that gets caught in them. Here it is up close. So these insoluble fibers of a protein called fibrin. Fibrin is the spider web. And anything that gets caught. So the red blood cell is actually not a player in the clot. But if it was there, it's like a fly going by. It just gets caught. So clotting is basically a cascade reaction. And it's kind of like, you remember when we did the renin-angiotensin-aldosterone system? We said that this starts with renin, but angiotensinogen is always around and ACE is always around, but they don't interact with one another generally. Same thing with clotting. We have all of these inactive proteins that are part of the clotting process that never interact with one another unless you actually start the whole process. And then what they do is this one activates this one, and this one activates this one, and this one activates this one, so we get a really quick effect, right? Most of these inactive proteins that are involved in the clotting process were made by the liver. So once again, we see the liver and the cardiovascular system just cannot leave each other alone. They're intimately involved. Are we okay with the concept? Okay, so what we are going to have is a cascade reaction. It's going to involve a whole bunch of factors. Most of them are made by the liver. It's sometimes called the coagulation cascade. And most of these factors are present all the time in inactive forms. Why not make them when you need them? It's not fast enough, right? So you have them there in inactive forms. So now I'm going to show you this, and you're going to hate it at first, and then I'll tell you what you're actually responsible for. First off, whenever they found a clotting factor, and there's at least 13 of them, they gave it a Roman numeral, which means you have to know Roman numerals. You should know at least 1 through 12 if you've been through anatomy, right? Right? I always have people ask me on the cranial nerve test, what is XII? And I'm like, that is something you should have studied. I'm not Roman either, and I learned it. What these have is they were named in the order that they were found, which means it doesn't have anything to do with the order that they're actually used. So I'm going to show you this, and you're going to hate it, and then you will hate it less, but you will still hate it. Okay, so look at this pathway. You will not have to memorize all of it. You will have to memorize the important points in it. Please note that here is inactive 12, right? 12A is just activated 12. Here's inactive 11. 11A is activated 11. So there are half as many as it looks like, first of all. Okay, and then second, I don't have you memorize all of them. I have to have you memorize important ones that are like occurring at important branch points. Okay, so what we are trying to get to is the spider web, which is right here, fibrin, right? That is the protein that forms the spider web. We will see that there are 2 ways to get there, but once you get here, you are going to get a clot anyway. So this is called the intrinsic pathway. This is called the extrinsic pathway. Once you get here, it doesn't matter how you got there. This is called the common pathway. Good? Common pathway? Okay, and we'll come back to each one of them in just a second. So what we are trying to do is we are trying to get fibrin and make it form a clot. Clotting takes from 3 to 6 minutes. And we will see that it requires calcium at multiple points. So I've told you guys all along that calcium is required for blood clotting. Okay, so the 3 stages in the formation of a clot are, watch here for just a second. Please note that this is a really important part, this 10A. Do you see that? Because that's where the common pathway starts, right? I'll get you there in just a second. There's 2 different ways of getting there. I'm going to come back to that in just a second. But once you get there, then it doesn't matter how you got there, and you're going to get a clot. Okay? So the formation of factor 10A, which is called prothrombinase, we'll talk about how you get there in just a second. But once you get to prothrombinase, let's see what you do. Okay, so this is not as bad as it looks. Okay, so once I get to prothrombinase, which is one that you will need to know, prothrombinase is factor 10A, and its long name is prothrombinase. We will see that there are two ways to get there, and we'll get there in just a second. Okay, what prothrombinase does is it interacts with something that's always around but not activated. Prothrombinase converts prothrombin to thrombin. Okay, before we go any further, let's look at names so that you have less memorization. Anytime you see the root throm, it means what? What does throm mean? It means clot, yes. Okay, so prothrombin before thrombin. The enzyme that does it, prothrombinase. Good? Okay, and then now that I've got thrombin, it can interact with something else that's always around. Thrombin converts fibrinogen, which is always around, to fibrin. And fibrin gets stabilized to form a clot. Okay, so this is where we were trying to get. One last thing, fibrinogen, literally the beginning of fibrin. Genesis, the beginning of fibrin. Good? Okay, so this process is basically just right here, right? Okay, I don't have you put on there the whole stabilizing process, but the stabilizing process is important. Is everybody okay with that? Okay. Okay, so now what we have to do is we have to go back and figure out how the heck we get here, right? Factor 10A. Okay, so the common pathway begins right here with factor 10A. So how do we get to factor 10A? You can get to 10A, which is prothrombinase, in two different ways. So let me tell you the names and do the descriptions, and then you match the names with the descriptions. There are two pathways. There is the extrinsic pathway and the intrinsic pathway. One of those two pathways it's initiated by chemicals from within the bloodstream. And the other one is initiated by chemicals released from the damaged vessel or damaged tissues. So which one do you think is the intrinsic pathway? Yeah, the first one. It is initiated by chemicals released from within the bloodstream. That's the intrinsic pathway. The other one is the extrinsic pathway, and it is initiated by chemicals released from the damaged vessel wall or damaged tissues. Does that make sense? So basically there's two different ways that you can start a blood clot. You can start it from within the tissue, or you can start it from the damaged wall. Or you could start both of them simultaneously if you wanted it to occur really quickly, right? Okay, so let's talk about the intrinsic pathway and the extrinsic pathway. So really the important part about the intrinsic pathway and the extrinsic pathway, okay, so the extrinsic pathway, what happens is, stick with me for a second, you have damaged tissue, yes, that releases something called tissue factor, also called tissue factor 3, abbreviated TF or TF3. And there is a cascade that starts with tissue factor and ends up with factor 10A. Do you see that? Do you have to memorize all of the factors in the middle? No. You have to memorize extrinsic pathway, tissue factor to common pathway. Does that make sense? Okay. So the damaged tissue releases tissue factor 3, activates a complex cascade resulting in the formation of prothrombinase. So what about the other way of getting there? The other way of getting there starts with our platelet party. Okay, so remember when the platelet party started, it could also start a clot. So what happened again was platelets were exposed to collagen, they got sticky. During that process of getting sticky, they started a platelet plug, but sometimes they also start a clot. And how they will start a clot is they start to release not tissue factor, but platelet factor. Yes? Platelet factor 3 is what it is. So platelet factor 3 right there and there. Platelet factor 3 will eventually get you to factor 10A. That make sense? So the take-home message of that one is from within the bloodstream, activated sticky platelets release platelet factor, to get you to the common pathway. Does that make sense? Okay, so once you get to the common pathway, nobody cares how you got there, right? So the common pathway begins when you have 10A, which is prothrombinase, and it doesn't matter how you got there. So here's a summary to make it simple. Okay, you ready? This is how you read this. So the extrinsic pathway is activated by tissue damage. Everybody good? Which releases tissue factor 3, and tissue factor 3 ultimately activates prothrombinase, and then prothrombinase converts prothrombin to thrombin, and thrombin converts fibrinogen to fibrin, and fibrin gets stabilized to form a clot. Does that make sense? Okay, and then let's go back and simplify the intrinsic pathway. The intrinsic pathway will start with collagen making sticky platelets, and the sticky platelets release platelet factor 3, yes? And platelet factor 3 activates prothrombinase, and prothrombinase converts prothrombin to thrombin, and thrombin converts fibrinogen to fibrin, which is stabilized to form a clot. Does that make sense? Okay, so what do you have to know? If any factor is mentioned by name or number in your notes, it is fair game. If it is not, I will not ask it. Okay? There are a whole bunch of them, but they have to be mentioned by name or number in your notes. Okay? If they're in the textbook and I didn't mention them in your notes, I promise you I won't ask you about them. Okay? All right, so let's add just a couple other things, not actually any more names or numbers, but just so you know, there are at least 13 different factors involved in all of this. And if you had a problem with any one of them, you could have a form of hemophilia. Does that make sense to you? Especially a big deal if it's in the common pathway. Does that make sense to you? It would be a big, big deal if it was in the common pathway. So there is actually a factor, where is factor 8? There's a form of hemophilia that's not on this particular cascade. It must be on the other part of the cascade. That's factor 8 hemophilia. That's the hemophilia associated with the European royal family. And it is an autosomal recessive disorder, which is apparently why you shouldn't marry your first cousin 17 times over in generation after generation. So the other thing is I want you to figure out where calcium is required. Is calcium required extrinsic pathway, intrinsic pathway, or common pathway? Common, yes? All of them, yes. So this is an important point for you guys to understand. If you have a calcium problem and it is not taken care of, you are going to have a clotting problem because it's required for extrinsic, intrinsic, and common pathway. Does that make sense? Okay, and then the last thing is to talk about this little guy and the whole vitamin K thing. So let's talk about vitamin K and prothrombin. Okay, so you have vitamin K. Vitamin K is a lipid-soluble vitamin that the bacteria in your large intestine make for you. So the neural flora that you have in your large intestine gets colonized about 8 days after birth. And as long as you are otherwise healthy, you are making vitamin K with those bacteria that is absorbed into your bloodstream. And the important part about vitamin K is that you need vitamin K in order for your liver to make prothrombin. Prothrombin is an important part of the story, right? So you are not going to clot appropriately if you don't have prothrombin because that's part of the common pathway. Do you see? Okay, so it's lipid soluble. You need bile from the liver to absorb it. And so let's talk about vitamin K and vitamin K injections. So what has happened for about, I wonder if it seems like it's been even longer than 50 years, for a while, is that we are aware that babies, since they haven't been using their digestive tract in really traditional ways, they've been primarily just growing their digestive tract. Newborns don't have this vitamin K population, so they do not have adequate levels of prothrombin in order to have normal clotting mechanisms. Does that make sense? And usually it takes them about 8 days to get the normal colonization of vitamin K in their gut. And the problem is that if anything happens to them during that first 8 days, they can bleed out like somebody on Coumadin or warfarin would, somebody on a blood thinner would, because they don't have vitamin K and they can't form prothrombin, and therefore they can't clot appropriately. So one of the things that's happened over about the last 5 years, and it is amazing to me, is that people have gotten all confused about the whole vaccination controversy, which isn't even a controversy in my mind, but and they think that vitamin K injections immediately given after birth are a vaccination. They're not actually activating your immune system. They're just providing a nutrient that you don't have adequate amounts of. So that if your baby gets injured or stuck, and also birth is kind of violent, guys. It ain't like a picnic, right? It's the hardest day of their life so far, right? So what happens is now parents are refusing vitamin K injections. And I know of 2 babies who have died in Utah over the last 6 months because of refusal of vitamin K injections.
They not just. Do you think they're just not understand? They just don't
No,
understand?
they probably don't. I mean, it's hard to be. Physiology is not an easy class, right? But also you need to have somebody who is willing to have that conversation with them in a way that they understand.
But don't the doctors do that prior to?
A lot of times nurses do it, and a lot of times it doesn't happen until the moment of, in which the mom is like really not there for making the decision. But the vitamin K, just so you know, is a lipid-soluble vitamin. It clears out of your system, the injected vitamin K, within about 8 to 10 days. And then their own vitamin K is ramping up during that particular time. If anything happens to them, they're really likely to bleed out. I mean, sometimes babies need to get stuck, right? Especially if there's anything wrong with them, they can need to get stuck. But yeah, so this is one of the sort of byproducts of this sort of anti-vaccine movement, is that they can't remember that everything that comes in a syringe is not a vaccine, right? Even if you didn't agree with vaccines, this is literally not a vaccine. It's just a nutrient. Go ahead.
So do some doctors like refuse circumcision then? If they don't like give it like vitamin K injection, or does that have anything to do with it?
Yes, a lot of doctors will not do circumcision any longer. And a lot of insurance doesn't pay for circumcision either.
Yeah.
So that's the whole. No, insurance doesn't pay for circumcision most of the time any longer. The American Association of Pediatrics doesn't recommend it any longer. And if you've got usually a lot of vitamin K rejectors would be anti-circumcision as well. That population would have a lot of overlap, right? That Venn diagram would look almost like a circle.
I'm just going to ask this, so why just give the shot? They don't really know they have to have, I'm like, you're protecting the child, so why don't they just give a shot?
They could, but you would have a hell of a lawsuit if somebody figured out that you gave them a shot without. It's not legislated or mandated. And so that one's an interesting one. What I'm hoping is that since you guys are in the next generation of healthcare professionals, then you will be the people who are smart enough to talk to someone in a way that is respectful and can educate them so that they can make better decisions, right?
So you
Right?
have to pay more to get your son circumcised.
Yeah,
Yeah, it's considered elective.
it's elective
I
now.
agree with, it's considered cosmetic and elective.
Yeah.
Our insurance didn't cover it for,
And insurance doesn't cover it very often.
but it was only like $175. They don't bill, like, it's not like thousands of dollars.
Because like an aspirin is $100.
They don't,
So
but it's cheaper if you do it at the pediatrician's office than if you do it at the hospital.
if you do it at the hospital.
Like, if there's
Yeah.
something like that.
So anyway, they're babies, you know? Everybody's all pro-baby until you have to do something to keep them alive, like a vaccine. They're like, let's have all the babies and let them die of natural causes. That's pretty much. Okay. So that's vitamin K. Vitamin K is not very controversial in other first world countries, FYI. It is, I don't know how it got controversial with here. My OBGYN says that she has had more vitamin K refusals in the last 5 years than she had in the previous 15 years. And it's like really, really difficult. She started having the conversation before she actually takes someone on as a client because she feels like responsible for that baby. She's like, I don't think that this is going to work. So anyway, clot retraction phase is next. The clot retraction phase is an interesting one. Somebody figured out about 20 years ago that platelets actually have actin and myosin in them. And when the cells around the clot start saying that they are healed, they start releasing paracrinagens. And the paracrinagens actually start a little bit of cross-bridge cycling in the platelets. And the platelets are all stuck in the spider web. And the spider web is all stuck to the collagen at the edges. And it starts to pull the edges of the wound closer together so that healing is easier. And that, by the way, is usually when you feel like that scab tightening up. Right? The scab is tightening up because of the healing process going on and the paracrinagens releasing and it pulls it together. So that's called the clot retraction phase. It's also usually when the serum is squished out. And by the way, serum is not pus. Pus is actually an indication of an infection, and it's usually a bunch of dead neutrophils. But this is actually just a clear fluid that gets pulled out. And then the very last phase is kind of interesting too. So when the cells are really, really healed, they will start to tell you that they're healed by releasing different paracrine agents than when they were damaged. And these different paracrine agents can actually start the process of breaking down the fibrin. And this last phase is called fibrinolysis. So healing, the healing tissues, this is a little bitty cascade, will release TPA, which is tissue plasminogen activator, which if you worked in the hospital, you've probably heard of it. I'll tell you how it's used clinically in just a second. TPA interacts with a plasma protein that's always around, which is called plasminogen. And plasminogen gets converted to plasmin. And plasmin is a big deal because plasmin dissolves fibrin. Does that make sense? So when the cells are healed, they're like, hey, we're fine. You can get rid of the clot. And they actually release something that dissolves fibrin. It doesn't do it directly, but it releases TPA, which activates that. So this one's a big deal because they figured out how to genetically engineer that and make it in the lab. And so TPA is a phenomenally effective clot buster. So if someone, for instance, had a stroke and you thought they might have a second stroke, right? Or they had a mini stroke or maybe what preceded a stroke, and you thought they might have a second one, you can administer TPA, but they have to be admitted to the hospital because it is such an effective clot buster that if anything happens to you, you will bleed out like a stuck pig, okay? So TPA, it's also really, really expensive. So they give TPA if you've got good insurance. They don't give it if you have bad insurance. So they will give you TPA for strokes. They don't give it for heart attacks very often because strokes have, a second stroke is so much worse than a second heart attack, right? Second heart attack, you're either going to live or die, but a second stroke completely impact your quality of life, your capacity to make decisions for yourself. Go ahead.
Is that one you have to get within 4 hours of the stroke?
I don't know. Is it the one that you have to get?
I don't know. There's one that like you can only have it within 4 hours of the stroke.
I would imagine
And
that
beyond
that's
4 hours,
probably it. I don't know how long you
I
can
would
get
think
this
so,
one.
because once you have one stroke, you're very susceptible.
Very
But
susceptible
if
to a
it's been
second one.
longer than 4 hours, they won't get it.
Somebody look it up. See if you can have it a long time or not. So, this is not a maintenance medication. Nobody's going to send you home on TPA. It's just too dangerous. Okay, so the last thing that we're going to talk about before we get into respiratory system is what makes you clot appropriately or inappropriately, right? What causes strokes and heart attacks, especially clot-based strokes and heart attacks, because there can be other forms. And how can you avoid it? So first is, let's talk about what keeps a clot. So we talked about what kept a platelet plug from continuing to go, right? What keeps a clot? Because a clot's a long positive feedback cascade too, in which you activate that, and that activates that, and that activates that. So why, when I form a clot, does it not fill up the entire vessel in a healthy person? Well, the fact is that you should only have all of these activated clotting factors close to an injury site, right, in a healthy person, okay? You can have inactive ones everywhere, but close to an injury site, either you're going to have something that starts the extrinsic pathway or the intrinsic pathway, right? And that's what should occur there. Everywhere else, you are carrying away the activated clotting factors. Here you are concentrating them because you're releasing a bunch of them. In addition, although there are rarely activated clotting factors or coagulants, there are always activated anticoagulants. So you've always got anticoagulants circulating in your system. Does that make sense? Heparin is one of them. It's always circulating in your system. It's made by basophils and mast cells. They've got another one called antithrombin. So basically, where you get a clot is wherever the concentration of activated coagulants far exceeds the concentration of anticoagulants, which we hope will only happen at the site of injury. But of course, we know it can happen inappropriately. We'll talk about that in just a second. Clinically, you can use these things to your advantage. Heparin, which you make, is also used to prevent clotting during surgery. It's also used in IVs to prevent clotting so that the IV actually stays fluid. Heparin is an anticoagulant because what it does is heparin destroys thrombin. That's what heparin does. It takes out thrombin. Does that make sense? So it's an anticoagulant in you. They use hep blocks, and they use it during surgery because you need to keep the blood flowing. I had to shoot myself up with heparin every day during my pregnancy because I had a heart problem, and then pregnancy increases your risk of clotting as well. So heparin is really, really commonly used. It's still really commonly used. What about other things that they sort of broadly call blood thinners? I hate this term because they don't change the viscosity of the blood. What they do is they make it less likely that you will form both appropriate and inappropriate clots. And I know you guys probably heard of Coumadin and warfarin. You guys heard of those? Coumadin and warfarin, what they are is vitamin K antagonists. And so, remember the vitamin K story we can go back to one more time. What you need vitamin K for is to make prothrombin. And these are vitamin K antagonists, right? So they make it so that vitamin K doesn't work properly. So your levels of prothrombin will decrease dramatically. They will give that for chronic hypertension or heart problems, or if you've already had a stroke or you've already had a heart attack and you're going to be on a blood thinner because of a stroke or heart attack in the past. But this, of course, also means that every time you run into something, you're going to get an enormous bruise. And if you were like my father-in-law, who's on Coumadin, right? He got a tooth pulled on Friday. He's still bleeding today, right? From having his tooth pulled on Friday. So clotting is problematic when you are on Coumadin and warfarin. So they really don't thin your blood. They just make it less likely that you're going to start the clotting or complete the clotting cascade. So that's Coumadin and warfarin and heparin. Okay, so one last little tidbit, and then we'll go into like inappropriate blood clotting and why that occurs. Why does the blood that you give at a blood drive not clot when you stick it in the fridge? Well, some smart person just figured out that if you could just tie up all the calcium ions, you can't do any of the pathways, right? And so they give this detergent called EDTA, which is not problematic, but what it does is it actually just ties up all the positive ions, including calcium. And since you tied up all the calcium, you can't clot. But it's not particularly problematic because then as soon as you squirt it into somebody else, they've got calcium, right? Does that make sense? So primarily, if you can take all the calcium away from the blood plasma, then you will have the blood won't clot, especially if you also keep it cold. Does that make sense? So that's what EDTA does. Okay, so last tidbit in blood is just what about inappropriate clotting? Inappropriate clotting happens in all of us. It happens relatively frequently. It happens anytime you slow down blood flow really dramatically because platelets like to attract other platelets, right? So what's the most likely place in your body for you to form a clot in a healthy person? Arteries or veins? Veins. Where? Legs, yes. Because I've got really low pressure, right? Because I'm in the veins, and I'm also working against gravity all the way back up to the heart. So all of us form clots in our legs. It's not problematic for most of us because we've got anticoagulants like circulating in our bloodstream. And if you're otherwise healthy, then your blood vessels are nice and wide anyway. When it becomes problematic is when you have an increased likelihood of clot formation because of whatever, and also narrowed vessels, right? So if you have great big wide vessels and you throw a clot and it goes straight through your coronary artery and nobody even notices, right? Or if it gets broken down long before it comes to your coronary artery, then you won't even ever notice that you actually had a clot, and all of us do. So most of them form in the blood vessels of our legs and then get broken down. But if it gets stuck in a blood vessel to your brain, it can cause a stroke, heart attack, lungs, pulmonary embolism. Anytime it's actually moving, when it's still, it's called thrombus, and when it moves, it's called an embolus. Okay, so what can cause inappropriate clotting? There are a lot of things. One of them is just a rough inner surface of your blood vessels. So arteriosclerosis and atherosclerosis sucks because it narrows the vessels, but it also sucks because it makes them lumpy. So it doesn't lay down nice and smooth. And anytime you've got a lumpy inner surface of your blood vessel, you're more likely to catch a platelet and start the whole intrinsic pathway. Does it make sense to you that inappropriate clotting is more likely to start with the intrinsic pathway than the extrinsic pathway? that make sense? Okay. So high blood pressure increases your likelihood of clots because it stretches your vessels, right? And when you stretch them, you're likely to get scarring on the walls of the vessels, which is not nice and smooth. So chronic hypertension can do that. Infections resulting in scarring. So may or may not make sense to you, but IV drug users, whether you were a recreational IV drug user or someone who had to inject things in your veins because of a medical situation, you are at a lifetime increased risk of heart attacks, strokes, and pulmonary embolisms because of all of the times you poked into the same vessel, right, or many vessels, and made them rough on the inner surface. Does that make sense? You're just way more likely to catch a platelet for the rest of your life. Okay, then the other thing, anything that makes your blood stay still increases your likelihood. So immobilized patients, once you mobilize them, if you have not been exercising them properly and moving them around and turning the patient, then they are increased likelihood of clots as soon as you start wiggling them. Or if you sit on a long plane ride, you're going to fly to Australia, right? They ask you to get up and start wiggling in the flight now. And it's not because they love you, it's because they don't want you to sue them or your family to sue them when you like die 2 days into your Australian vacation that you saved up for your entire life. Or my atrial fibrillation problem, can you see why it increases the likelihood of clots? Because the blood, instead of getting squished from the atrium to the ventricle, just sits up there, right? So if I have a decent bout, I have to like shoot myself up with heparin for 2 weeks afterward, after I have a decent bout of atrial fibrillation. Okay, and then this one has a question mark, just because the data is not as strong for this one, but it's not going to hurt you to actually engage in this one. So it seems as if the more antioxidants you have in your diet, antioxidants are primarily from these vitamins, C, E, beta-carotene, selenium. Best way to know whether you're getting antioxidants if you are eating things that are bright in color in their natural state. Usually they are pretty rich in antioxidants, especially red foods and purple foods and those kinds of things. So if your vegetables are all potato colored, you're probably not getting a lot of antioxidants. And if you cook the living crap out of everything before you eat it, you're probably not getting a lot of antioxidants. What's the deal with antioxidants? It seems as if, and the research is not as strong for this one as it is for the other ones, it seems as if oxidized cholesterol, LDL and HDL, stick, right? So if you have high levels of antioxidants in your system, then the cholesterol that you eat is less likely to stick. Does that make sense to you guys? So there is a decent amount of literature to support this, but what's the worst that could happen? You get some good vitamins in your system that you know you're supposed to be eating anyway, right? The other thing that's really nasty about this one is smoking zaps antioxidants from your system, right? And so, like I told you guys, smokers have the stickiest, gunkiest vessels of anyone. Even if they are not fat people, they have the fattest vessels I've ever seen. Toothpaste vessels, just squirted out. It's the nastiest thing ever. That's what they need to show when they're doing anti-smoking campaigns, is like squished out of the vessels. Okay, so, and then the last one is high levels of estrogen. So estrogen makes your platelets stickier. It makes them more likely to attract other platelets. And so in the old days when birth control pills were first out, so I think birth control pills became available between my brother and I think so. So my mom always told us that he was a sponge baby and I was a pill baby. So she's very, very sentimental. So I think it's funny now that I'm a mom. Birth control pills became available then, and when they were first available, they were really high levels of estrogen. And high levels of estrogen increased platelets being sticky, so birth control increased your risk of strokes and heart attacks pretty distinctly. Now does it still? Well, it's still estrogen, although there are progesterone-only pills that don't. But the levels of estrogen, they've gotten them down to the lowest level that actually works. So it's nowhere near as much as it used to be. But if you have a responsible OBGYN, they will not give you birth control if you are also a smoker. But then what do people do? They just go to another doctor, right, and get it. So you shouldn't compile risk factors. And since I have atrial fibrillation, when I went in to get birth control, they're like, okay, you've already got one risk factor. We can give you this other one if you can guarantee me that you don't have these other 20. right? You don't do all of the rest of these things. In the old days, so they make your platelets stickier. That's why when I was pregnant and I had atrial fibrillation and high levels of estrogen during my entire pregnancy, I had to shoot myself up with heparin every day to get through the pregnancy. So that's how that works. Okay, so we're done with blood.
So the TPA has to be administered within 3 and up to 4.5 hours.
3 to 4.5 hours. I wonder why.
It's
It says right there. You guys are going to teach me something.
Was the
Huh.
protein plasminogen that is the clot? Was the clot? What
It's
protein
plasmin.
was the clot? Okay, that's-
Plasmin's the clot buster. Well, actually, TPA is administered as the clot buster, but the thing that actually busts the clot is this guy right here.
Okay.
Plasmin busts fibrin.
I would wonder if they need it that quickly after, because when you come in, you can kind of tell, you can just kind of observe a patient and kind of tell that they're having a stroke. I mean, there's certain
You can.
things that you do
Uh-huh.
to see if they're having strokes. But I wonder if another clot will form very quickly.
I don't know, but can you see why or no? Go ahead.
So plasmin busts fibrin
Yes.
and heparin.
Heparin destroys thrombin. Yeah, heparin destroys thrombin.
So it can never get to fibrin.
Yes, exactly. So heparin is given as a maintenance medication, right? Does that make sense? You can take heparin regularly. This one is like an acute medication. It's a clot buster for a clot that already exists. Does that make sense? Like even if, you can't, but even if you could take TPA daily as a clot buster, it doesn't do a damn thing unless you have a clot, right? That makes sense? But this one will prevent clot formation. That's the idea. Okay?
So Princess Leia, aka Princess, what's her?
Carrie Fisher.
Carrie Fisher.
Died on her ride back from London after filming.
She did?
Yeah, and
She
she
had a
had
massive heart attack.
a massive heart attack. Is that from sitting too long?
No, it's probably all the drugs she's done.
Well, that too.
That's quite a story of history.
Yeah.
But sitting on the plane for a long period of time probably didn't help,
In
right?
Princess, you're like,
Right.
But right wasn't the plan. It
Sorry.
was what led up in the
she's really lucky that she lived that long.
Oh, no.
Did she almost died before?
Yeah, she did. She almost
Probably
died
a few
before.
times.
Yeah.
Her mom outlived her, but like just a
A day.
day.
A day.
Is it a day? It's amazing to me. Okay, so we're going to start on the respiratory system. We're not going to do anything hard today. Here's what's going to happen. I am going to start on the respiratory system, give you an overview. Then I'm going to post a video for you guys to watch between today and Wednesday. And I know you'll go find it because you want your grades. So you'll actually visit my website, some of you who never do. I don't even know how the hell you're passing this class, honestly. You're like, I can't get into your website. I haven't been able to get in all semester long. What the hell? What are you doing? I don't even know what you're doing. They're either brilliant or stupid. There's only two extremes. Fine. I don't know. Look at that. Wells Fargo. That was me. Okay. So I will post that for you. But today I just want to give you the intro to the respiratory system. So with the intro to the respiratory system, okay. First off, interactive physiology is really good for respiratory system. I know you guys are like busy, but you're about to take your lab practical, so you're going to have a little bit more time, right? Lab's going to be done on Wednesday. You're going to have a whole week to think about nothing but lecture, right? Okay, so interactive physiology is really good for respiratory system for those of you who like using it. Some of you guys don't remember any of the respiratory anatomy, so you should know if you don't remember that. So the first thing I'm going to do is just talk to you guys about the terminology associated with the respiratory system. Just terminology. Oh, wait, I want to show you one more thing. Before we do that, rewind for a second. I'm going to post this figure for you. This figure is a really good review of the things that I think are important about blood clotting, okay? And the things that are in red are the things that I expect you to be able to fill in. Notice how freaking easy it is, okay? So I'm going to post this for you. This is just a visual representation of the same stuff that we've been through. Okay, please note that if we're doing tissue damage, it starts the what pathway? Extrinsic. So what if I posted this without all of the red in there? It would still be on the video, but you'd have to go back and review it just to fill it in, and that would be studying. Okay, so the tissue damage starts the extrinsic pathway, and tissue damage causes the release of tissue factor 3, which ultimately will get you to the common pathway, right? And then the common pathway starts when factor 10 gets converted to factor 10A, which is what? Prothrombinase. And prothrombinase converts what to thrombin? Prothrombin to thrombin, which converts fibrinogen to fibrin, which forms the clot, right? That makes sense? And then this one, right here, is the intrinsic pathway. It doesn't show you, but this one starts with sticky platelets, right? Sticky platelets ultimately releasing platelet factor 3, yes? The intrinsic pathway, platelet factor 3, and platelet factor 3 will get you to the common pathway, right? And the common pathway generates factor 10A, which is prothrombinase, which converts prothrombin to thrombin, and which converts fibrinogen to fibrin. Okay, so I will upload this for you guys. Good? Okay, all right, now we can talk about the respiratory system. I forgot I did that. Okay, so with the respiratory system, let's talk briefly about the big picture of the respiratory system. So with the big picture of the respiratory system, what we are going to have, no, not that one. Okay, so we are going to have external respiration and internal respiration. Okay, respiration is anytime you're doing gas exchange. External respiration is everything but cellular respiration. Okay, cellular respiration is all the way internal at the cellular level. What I'm going to tell you is the entire respiratory system is trying to serve cellular respiration. Cellular respiration is constantly generating concentration gradients for oxygen and carbon dioxide. Why? Because it never stops using oxygen, so you're always gobbling up oxygen, and therefore it's generating low concentration of oxygen in respiring tissues, right? And you're never not doing cellular respiration, you're never not producing carbon dioxide, so it's always generating a high concentration of carbon dioxide, right? Does that make sense? So all of this respiratory system is going to be to serve internal respiration, which is cellular respiration. So external respiration, here's what we're going to do. Our objective is going to be to get air into the body. And what we are going to do in order to make that occur is modify the size of this container and therefore the pressure in this container. Okay? So Boyle's gas law, which you may or may not remember from any physics you've ever took, says that there's an inverse relationship between the size of a container and the pressure in a container. So if I take a container and I squish it, what happens to the pressure? Goes higher. And I stretch it, what happens to the pressure? Goes lower. Okay, so what we are going to do is we are going to understand that air moves like fluids from high pressure to low pressure, yes? And the pressure out here is relatively constant. It's called atmospheric pressure. It's about 760 millimeters of mercury. And I've got a container here. And what I can do is squish the container and stretch the container. And what I'm going to do is change the pressure in this container so that it goes below atmospheric pressure and above atmospheric pressure. So here's what happens. Inspiration, which is the first part of ventilation, tells me the inspiration will take my diaphragm, okay, and it's going to take it from its relaxed position all the way down here, and it's going to take my external intercostal muscles and pull them up. What am I going to do the size of this container? I'm going to increase the size and therefore do what to the pressure? Decrease the pressure. When I drop the pressure below atmospheric pressure, air moves passively in. Does that make sense? Right? All I'm doing is dropping the pressure by changing the size of the container. Okay? Now I want to do expiration. When I do expiration, what I'm going to do is I am going to relax the diaphragm, relax the external intercostal muscles. What am I doing to the size of this container? Decreasing the size of the container. What am I doing to the pressure? Increasing the pressure. As soon as the pressure goes above atmospheric pressure, then air will move passively out. Does that make sense? So that's what's happening in the respiratory system. I'm just changing the size and the pressure. Did you guys do respiratory system in lab? Is there a respiratory? Okay. Do you remember? So inspiration is primarily what muscles? Do you remember? Diaphragm, external intercostal muscles. It's making the thorax really big, and the lungs follow it. Do you remember how expiration occurs or no? Expiration is primarily a relaxation process. When you're doing normal tidal breathing, all you have to do is relax the diaphragm and relax the external intercostals, and the pressure goes above atmospheric pressure. But if I'm blowing out a birthday candle, then I can involve two more muscles. That's forced expiration. I also do it when I'm working out. Forced expiration involves two more muscles, and they are your internal intercostals internal intercostals squish the ribs together, right? Make the box a little bit smaller. And then your abdominal muscles, which push the diaphragm from the bottom, right, to make it smaller. And you can feel that in yourself, right? If you like blow out earthly kind of, you can feel that actually occurring. You can actually feel your ribs pulling closer together as well. You don't do that all the time. You only do that during forced expiration. Okay, so basically what we are going to do is we're going to talk about ventilation, and that's what we have been talking about. It'll be easy because we've already gone through it once, and I'll post a video for you guys. And then after we've done ventilation, which is getting the air in, now we have to get the gases to move across the epithelial membrane, right? So we need oxygen. At the pulmonary capillaries, what we need is oxygen to move into the bloodstream and carbon dioxide to move out of the bloodstream. Luckily, it's pretty damn easy because they're lipid soluble, guys. They move straight across. And you've got a tremendous surface area. So what we are going to do is respiration right here at the pulmonary capillaries. Then we're going to, of course, send it back to the heart, and then we're going to pump it to the systemic capillaries. And at the systemic capillaries, you're going to do exactly the opposite, right? You are going to drop off oxygen off of hemoglobin, right? And you are going to pick up carbon dioxide, and then you are going to deliver them back to the lungs. So all we are going to have to do is to note the exact physiological way that you do that. But most of it is really easy because it's based on concentration gradients, and you load it onto hemoglobin, and then you unload it off of hemoglobin. So it's not going to be super difficult, right? So, so let's just get started with the very beginning of it. All right, so let's talk about ventilation and lung mechanics, which is pulmonary. Pulmonary ventilation is the fancy way of saying breathing. Okay, it's not gas exchange, it's getting the air in. Okay, interactive physiology is phenomenal on this. I just watched it before class. So the size of the thoracic cavity increases due to the contraction of the diaphragm and the external intercostals. I hate that the external intercostals are involved in inspiration and the internal intercostals are involved in expiration, but that's the way it is. Sorry. I wish it was the other way around. So the increase in the size of the thorax decreases the pressure, right? And the lungs, by the way, are passive elastic structures. And what happens is I'm really increasing the size of the thorax. But what I have is the lungs are actually stuck to the wall of the thorax because it's a moist membrane. There's lots of hydrogen bonding and there's negative pressure in there. So it's like two glass slides that are stuck together, right? As long as you don't allow any air to get between the slides, right, then it's really hard to pull the damn things apart. So what happens here is I increase the size of the thorax, and as long as there's negative pressure and moisture between the visceral and the parietal pleura, then the lungs just stretch out with the thorax. Does that make sense to you guys? Okay. What happens if I get a pneumothorax and somebody punctures a hole? What happens to my lung? Collapses because the lung is an elastic structure, right? It's elastic so that you can pull it out, right? But when you relax, it's also going to snap back. So if you actually put air between the two glass slides, the whole damn thing is going to elastically recoil on itself, right? So we depend on that negative air pressure in there. In a pneumothorax situation, and I wasn't going to talk about this yet, but I'll go ahead and show it to you, and we'll show it to you again next time. In a pneumothorax situation, what happens, oh balls, did I not bring it up? In a pneumothorax situation, what do they do if your lung actually collapses? What do they do? So yeah, and what they do is they actually suck out the air again, right? And they form another vacuum, right? And then the moist membranes adhere to one another again, and as long as you keep the negative pressure in there and allow for it to heal, then the lung will like sort of passively realign with the wall, right? So interestingly, you can and do collapse lungs usually by not even touching the lung, right? All you do is allow air into that side, and you're allowing some air to get between the two glass slides, and the lung just sort of folds in on itself. I'll show you guys a pneumothorax picture next time, so I can't remember where it is. Okay, so that's inspiration. And then expiration is when respiratory muscles relax. Like I said, it's primarily the relaxing the diaphragm and the external intercostals. And because of that, the elastic basement membrane in the lungs, the elastic basement membrane in the alveoli, and also the pleura, will recoil back into the relaxed shape. And when they do that, not only do you decrease the size of the whole container, you decrease the size of all of the little containers too, right? If the basement membrane of each alveolus has elasticity, when you stretch it out, it gets bigger, but then what happens when you relax it? It actually helps push the air out a little bit. Does that make sense? So that elastic recoil will allow for the air to move out. So normally expiration is a passive process. It's just relaxing of muscles, but the internal intercostal muscles and the abdominal muscles can also help to push it out if they need to. Okay, we're going to stop there before we actually get into pulmonary ventilation. Huh?
Oh, sorry, I was saying always here. Same thing.
Okay.